we'll wrap it up. Okay, so you haven't seen this one before, and this was a slide that is going to take you through details of accounting, debits and credits. Okay, but we're not going to do that, this bottom part. It's very confusing, but it basically shows you how on the income statement and balance sheet, how journal entries get made and debits and credits, things like that. Very boring. You don't need to know about it. The reason I put it up here is this top part, because it showed the income statement as revenues and expenses, and the balance sheet has assets and liabilities and equities, right? Those are the equations that I've been hammering through. And those are actually composed of debits and credits. Debits are pluses and credits are minuses, you know, but that's the double entry system of accounting. If you hear debits and credits, that's what we're talking about. But really, what I put this up because we're going to talk about how these things relate to each other, okay? So they relate to each other in terms of return on investment analysis, all right? So that's what we're going to learn today. It's a primary lesson, return on investment. So the way this works is the first thing we start with when you look at an investment is something called turnover. Okay, turnover is the relationship of revenue to assets. So if we make an investment, that's an asset. All right, we bought some equipment or invested in a building or did something like that, IT, whatever. And typically when we do that, we expect there to be some type of revenue, or it could be expense reduction, but something good will happen from us doing that. Okay, so that relationship is called turnover, and revenue divided by assets. And it's essentially a measure of our efficiency of deploying assets. It's a measure of how good decisions are we making about investing assets. Okay. The next thing is operating efficiency, which we use, we call that alternatively operating income, EBITDA margin, things like that. Those are all measuring the same thing, which is how effective are we at turning revenue into income. So revenue minus expense equal income, right? Now you might think that, you know, the better you are at generating revenue, the easier it is to make income, and that's actually true. So then the next thing is called return on investment, or return on assets, or return on, this is actually ROI, which is income over assets. Okay, so that means if we made an investment, how much income comes back to us. Now, if any of you had, I guess it's algebra, you'll notice something here. If you took these two formulas and multiplied them together, you get this. Because what you do is you would strike out revenue, and you have income divided by assets, which is what this is. Okay. So it's like a really neat little mathematical fact. Okay. Then that's called return on investment or return on assets. But down here we have something called return on equity, which is a little different. And the difference is the use of what we call leverage or debt. Okay, and basically what I'm going to show you is that you can sort of, from a financial engineering standpoint, look at all these things to manage how much you can invest in assets and what kind of a return we get on the bottom line in terms of return on equity. Okay, and if you multiply these two things together, you get that equation because you cross out assets, and get income. Okay, which is good. Okay, so far so good. Okay. Don't worry, we're going to go through this in detail so you can see it. That was the theory. Now you're going to get the practical aspect of it. Okay, so let's take an investment, and let's say this investment is that first column. Call it FQHC. You guys know what an FQHC is? Federally Qualified Health Center, and it's the ambulatory clinics like Hayward or wherever else we have in Newark. And we get paid extra rates. We get paid $250 to $300 a visit every time the patient goes to those clinics. It's a special advantage we have. But let's say that we decided we needed a new one. Okay, we needed to put one, say, in North Allegheny County, because all of ours are in the south. We have coverage up in Berkeley or Richmond, that area. Okay, well, the first question we have is, how much does it cost to start an FQHC? So if we're going to set up an FQHC, and that's basically a medical office building with a bunch of little office, exam rooms and furniture, desks, exam tables, things like that. How much do you think that would cost? Any guesses? My guess is about $5 million. Okay. Now the numbers I'm going to show you today are kind of rough estimates, but I've been in the business for a while. I think they're in the ballpark. Okay. Big picture ballpark. Okay. So let's say we decided that we wanted another one. We agreed to spend $5 million. And when you spend money, you have a choice. You can kind of spend your own money, or you can borrow. Okay. But let's say in this simple case that we decided to use our own money. Let's say we had an extra $5 million laying around. We're going to invest $5 million. Okay. There's no debts. There's no interest expense. Well, then the next question is, well, how much revenue do you think we could generate from that FQHC a year? And that's sort of a function of, well, how many patients can you run through? What the rates you get paid are. But let's say, for example, that we thought we could generate $25 million a year from the FQHC, which might be a little high, but I think it's not wildly off, because we have 4 today, and they generate on average, 80 million. So it's probably pretty close. Okay, so that's that. And then the question is, well, can you make money with that? Can you have profit? And so that's the relationship of this sort of contribution margin to break-even analysis. So what we would do is we would say, well, if we have this many patients, how many doctors do we need? How many nurses do we need? How much medical supplies, other things like that. We would do a projection. And in this case, let's say we figured our cost would be 22.5, so we make $2.5 million. Okay? So, is that a good deal for us to do? You think? Let's look. Go ahead.
I think the ROI is not where it needs to be.
What do you think it needs to be?
Well, if you invest 5 and then you get 50% in return, at least we should get 75% in return.
Why?
Maybe by charging patients more.
Well, why do you think we need 75 versus 50 versus?
Well, is it a yearly base?
This is a yearly basis.
Okay.
1 year.
Okay. I didn't.
Okay, so the fundamental concept of making investments is, whatever it is, you want to get your money back, plus make a profit.
Yes.
Over the life of the project.
For how many years?
2 years of paper itself.
So in 2 years you make the money.
Yeah.
Okay. I understand.
That's pretty good.
Yeah.
And this is the bottom line, profit, you don't know, will that clinic have OB portion that sends patients here that increases our revenue?
There's that too.
Yeah.
There's the following.
But if you were to increase patients, the cost of patients,
Yes.
the service, how will that give you at least?
You could, all those things. So let's say, in this case, the 25 includes the follow-on business that's going to come over here. When we do these, we look at the impact on the whole system. But so one question would be, well, should we do this? Well, let's look at it from this construct that we're talking about. So the first thing is, what is the asset turnover? So what is revenue, annual revenue divided by assets for this investment?
So it would be 200. Yeah.
So 2 times, that's,
That's not
yeah,
bad.
so we invest 5 million, actually, that's not right. Oh, I got a problem with my form, this is actually supposed to be 5.
Yeah.
Okay. I'm doing this one.
In front of the TV.
Okay, but let's follow through, that's a good catch. So this would actually be 5, because it's 25 divided by 5.
Fine, yes.
Okay, what is the operating margin? It'd be pretty easy, right? 10%.
Percent, yes.
And how do you get 10%? What is it? Which line divided by which line? It's, okay, here's the key, I divided by R. So
It's
income,
this.
this line, 2.5,
By
divided by
25.
revenue. Okay, so 10%. The return on assets would be, again, I think they have performed this wrong. I think it's very simple. It would be income, 2.5 divided by
Fine.
assets,
Yes.
5 million. So that's what, 50%? Okay. Oh, so that actually is 50%. All right. And coincidentally, if we multiply, if that was the right number, 500 times 10% equals 50%.
50%, yes.
Right, okay. And in this case, I've used no debt. All right, so ROI is the same as ROE. Right? Everybody's good so far? Okay. Now, let's say we introduce the concept of leverage or your debt. Okay, so we left everything the same, but we said, rather than using our own money, 5 million, let's borrow 2.5 and only spend 2.5. Okay. And what happens there? Well, this is all wrong. I can't believe it. No, I messed this up. I can't believe it. Ugh. All right. I'm really disappointed here. Okay, anyway. I think probably that was supposed to be 10 million. But it looks like the margin would have been the same. Okay, all right. That's what I did wrong. Never mind. So in this case, let's just follow through. So in this case, if we have 10 million of revenue, and we have a 10% margin, but then we borrow 2.5 million at 6%, that's $150,000. Okay, so the 150 comes off here. Now we're making, instead of making $1 million on 10, we're making 850. So our margin has dropped from 10 to 8.5. Everybody see that? Okay. But our return on assets is 17%.
It's less.
Okay. And the reason is that you basically multiply these two numbers together. Then what I'm trying to demonstrate here is the effect of leverage here is that you double the return on equity.
So does the 10 million include the service that each patient will be charged, like when they come in for service?
Yes.
Okay.
Yes.
And so how much is it there? How much each patient will be charged for
Yeah.
each
Yeah.
service?
So that part is we have this whole elaborate process where we do financial pro formas.
Mhm.
We sit down with the operating executives and how many patients do you expect to see, what staffing is required, what's the payer mix, who's going to be paying us for these services, how much are they going to be paying us. And we do this big elaborate projection. So I brought this all down to a very simple aspect. So anyway, what I'm trying to show you here is that the effect of leverage, depending on how much you borrow, in this case half, is to double return on equity. Now, if you're losing money, it'll double the losses as well, or whatever ratio,
Do you pay interest in it?
and you pay interest. So then that's the next question. Is, well, what if in this case we borrow money at 6%, right? What if we could only borrow at 18%? What happens then? Okay, well, the interest is more, so that comes off. So now we have a lower return, only 5.5%. But we wind up with increase. It's still not, it's not as good as that, but it's still okay. Then the question is, well, at what interest rate does this project become unfeasible? And that actually works out to be 40%. So at this point, you have no income. Okay. Which actually also is another financial concept called the internal rate of return, which basically means if you take a project and you look at your costs and you look at all of your projected income in the future and bring it back, what interest rate balances the cash out at front, the cash in back? That's called internal rate of return, 44, in this case 40%. And then what you typically do is you compare that to what's called a hurdle rate. So anybody have heard the concept of a hurdle rate? A hurdle rate is a number that an organization determines for itself, basically to say, we're not going to do any project unless it has at least this return on investment. Okay? The reason they do that is there's a certain cost of capital. Okay?
There's a certain cost of capital, so you don't want to be investing in projects that return less than you can borrow money for. Okay? Because if you do, then you're going to be losing money. You want to, that's called negative arbitrage. You want to have positive arbitrage. You want to have a return that's higher than your cost of capital. So it's really important, this is called interest rate, but it could be called cost of capital, to know what your internal cost of capital is, to identify what your internal hurdle rate is. Because otherwise, you'd say, well, anything with a 1% return we would do, but in actuality, it costs us more than that, okay? All right, so that's a basic example. Now let's get a little bit more complex, all right? Let's look at multiple projects, okay? So these are individual projects. We have medical equipment. We could borrow medical equipment for $10 million. Here's that FQ8C, okay? In this case, I've got the calculation correct. $5 million. We could put an electronic health record in, new electronic health record. That's going to cost about $100 million, okay? We could rebuild our Sorian financial system. That's the system we use to bill and collect money. We could relocate our rehab unit. Okay, that would cost about $30 million. Or we could build a new wing at John George for about $25 million. Okay? So these are real approximate examples. The projects are real. The numbers here I've sort of estimated just roughly, okay? So if we bought medical equipment, say it's a new device that's used in surgery, okay, where it's going to allow our surgeons to do procedures that they didn't do before, or maybe we buy a PET scanner, so we're now doing PET scans, getting paid for those, something like that. In this case, let's say it generated annual revenues of $20 million, and the expenses are only $2 million, okay? Right? So let's look at that. So what is the asset turnover of that investment? Now the turnover, so that's a revenue, which is this number, divided by assets, which is that number. What's that ratio? 200%. Okay, so it has a turnover ratio of 200, okay? What is the next thing we want to know is the operating margin. What is the operating return from that investment? 90%. That's a pretty good operating margin, right? So multiply those two things together, you get a return on investment of 180%. Wow. In this case, we have no leverage, no debt, so these two are the same, okay? Let's look at the next one, do the same thing. This is the one we did. Let's skip that. Let's go to this one, electronic health record, okay? What's the cost? And what's the revenue? 10. Does that seem right?
No.
Why?
Well, we have, how do you capture what you make from a?
Yeah, because we already have electronic health
Right.
record. It doesn't work very well, but we
Right,
have one.
Right,
And we've already got the revenue.
right.
So the question is, if we put a new one in, what will be the incremental revenue? What will be the incremental change from what we're doing today? Okay? I said 10. It's probably not 0,
Yeah.
you know, because we've got to be missing something because documentation doesn't get done, whatever, something.
I
I-
see the big picture.
Okay.
We should reveal sort of financials.
Well, okay. So, also though, in this case, we've got more expenses. Here, we actually might reduce expenses, maybe.
Maybe.
I mean,
Not, you're not gonna see that very quickly.
No.
See it like-
It might go both ways, because we might be, I mean, if we put a new HR in, there's a big upfront cost, which is 100, and then there's an annual cost,
Yes.
which we'd have to make. But we're already making an annual payment to Cerner. So if we do it right, that would go away. So maybe we're just swapping one for one, or maybe the new one costs more than the old one. I don't know.
Does that include maintenance?
Well, then there's there's maintenance, yeah. And then there's the effect on the organization. So maybe we're paying more in IT, but maybe it makes everybody's jobs easier,
Yeah.
and we're more efficient.
Yeah, isn't
How
it
about
big?
safety for patients? I mean, we're saving money on data by not having.
There's that, yeah. There's that. Okay, so I don't know. So I just said, well, what if we had 10 more million in revenue and net we saved 10 million, so there's 20 million. So it's got a really low turnover, but you know, the margin in this case on a low volume is 200. So, but the return on assets only 20%. Not bad, probably above our hurdle rate. Okay, so we would probably do it, and particularly if we know that, you know, we have to do it at some point anyway. Right.
Yeah.
Okay. So
Sorry if I'm jumping ahead, but
Yeah.
when you go to Sorin Financials, would you have to rebuild that, or would it be part of the new electronic health record?
the new electronic health record does not encompass that functionality. So we are
But we still need to utilize Sorin Financials.
we absolutely have to. Otherwise, we can't bill for what we're doing. So we're going to probably be riding that horse no matter what we do. Okay. Yeah. So there's Sorian. So the cost there is about 5 million. Big return though. We can get a lot of revenue that we're missing, and probably actually reduce expenses because we're wasting a lot of effort right now. So that's got a pretty good return on investment. Yeah. Okay. How about rehab? 30 million. Okay. Now we have a rehab center today. So the question would be, how much revenue would we add? Or you could look at it and say, well, yeah, we have that revenue today, but it's in a building that is not seismically compliant. So if we don't do this, we're going to lose everything. So you could look at it both ways. You know, I chose to say, we're going to lose that revenue if we don't do something. We have to do something, so let's give them credit for the revenue. Okay. And maybe they grow a little bit, maybe they do something a little bit better. So that has a 20% turnover, and that I'm looking at is wrong because that's supposed to be 100. That's what happens when you drink and do Excel spreadsheets. It does have a 20% margin, and so it has a positive return on investment. Then we have John George. That's about 25 million. It's got, say, 20 million of revenue for a new wing, 80% turnover, positive margin, positive ROI, and positive ROE so far. Everybody so good? Good so far? So that in total, we'd say, okay, if we did all those things, that's $175 million. It's going to increase our revenue by 130, reduce expenses increase expenses overall. So our income goes up by $80 million. Okay. That's essentially a 50% return on investment. Okay. Pretty good. So in total, if we had $175 million, we would probably say, let's do all of those things, okay? Problem is, we don't have $175 million, okay? We have 30 million this year, 35 million next year, 40 million the year after that, 45, blah, blah, blah. So maybe over 5 years, we can do all this. But in a shorter time period, we don't. So now we have to start making some decisions. Okay, we have to say, well, let's start asking some questions here. Okay, which of these projects should be funded? Okay, what if we said we had $100 million? Okay, which of these projects, if you had $100 million to spend, would you do next year?
Solar and financials would be definitely one, probably all except the EHR.
Yeah, and you'd still have 25 million left over, right. So you could maybe start the EHR.
Exactly.
Okay. What if we had only $30 million?
When we lose the rehab?
Yeah, when did we lose the rehab? We lose the rehab in 2019.
Oh, so then we would-
But how long does it take to build a new rehab?
Oh,
Yeah, yeah. So we actually have to start that rehab center this year. We don't really have a choice. Okay, now, it's going to take a couple years, so maybe we only spend $5 million this year, and we put the rest in the next 2 years. So you kind of hit on it. So you don't look at it as just 1 year. So if we had a 3-year time horizon, that's 75, like $105 million over 3 years. So we can start making progress on a lot of this stuff, okay? But which of these would you do, if you had to look at this, how would you decide what order to do these in?
well, you want to be able to collect the money first, so you want to
Yeah.
take solar in,
Yeah,
that's a priority.
so you'd want to
Financials.
do the things that produce the highest return first, because that gives you more money, right? Okay, so in finance, they teach you this little technique. So here are all these projects, okay, and we're looking at the cash out the door, 175 million, and the annual income, 87.5. Here's the return, boom, 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 boom. So in finance, what they teach you to do is, okay, we take it and sort them by the return, put the highest return on top, boom, 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 boom. Okay, and do those, you know. So in fact, if you had, you know, $30 million, you do these 3, okay, that's 20. You'd take another 10 and you'd start these things, right? Okay, if you had more, you'd do more, okay? So far, so good? All right. Okay. Now, what if we said, yeah, but, you know, we don't have 100 million, we only got 50, but we want to do everything anyway, you know, just like, so if you're going shopping and you have $100 in your pocket and you find something you want and it's $200 and you say, do you say, well, I've only got 100, I can't do it, or do you use your credit card and you borrow, right? Borrow. Yeah, so we can do the same thing on a grander scale, right? Okay, so let's look at this line here, borrowing. $125 million. Let's say we decided that we could somehow borrow. I'm not saying we can, but let's saying we somehow created the ability to borrow money. Okay, that's why all this other stuff we talked about credit worthiness is important, because when you're credit worthy, people will lend you money. When you're not credit worthy, they won't lend you any money. Okay, so in this case, let's say we could borrow 125, and we said, okay, we're going to borrow it against these projects, and we have an interest rate, so we're going to pay interest. We know that. That's just the cost of doing business. In this case, that would be $7.5 million a year, which is a lot of money, okay, at 6%, which is about what we'd have to pay today, okay. Well, what happens is the return is a little less. So I think before it was like 80 or 87.5. Now it's down to 61, the margin, because of the interest cost. The return on assets are down, 45.7. Before we had 50, okay? So the ROI is down a little bit, but look at the return on equity, 160, because we've used leverage and we could afford it and we're profitable. We have a very high return on equity, which means the performance of the organization is going to improve much more rapidly than it would have otherwise. Okay? Okay. I think that might be it. Yeah. So that's the philosophy. Now, here's the real list. Okay? Now, you know, see this note up here that, you know, we're doing this strategic planning process. So we created this list now, you know, 5 months ago. But we're doing this strategic plan, and as we're going through the plan, we're saying, well, wait a minute, there might be a different direction we're going. So might we need to come back and look at this list and go through that exercise and see if it's complete and see if we have the same priorities that we did before, right? Okay. So that kind of leads us into the strategic planning process. So let's talk about that. Okay. Oh, one more thing first. Okay, so there's another technique. This has been around since I was in college, I think. It's called the Boston Consulting Group model. But it's a way of looking at these projects and deciding which ones should be done, okay? And essentially what it did is it said you should take all of your your existing operations, okay? This is not just new projects, but existing. Because one way to improve operations is to look at what we're currently doing and say, well, should we keep everything? You know, because maybe it's better to trade some out and do some other things, okay? This is a way of looking at that. So what they said was, you know, really you ought to look at things two ways. One is by your market share, okay? High market share, low market share. And the other is growth. Is this program growing or not? Okay? And then said, okay, well, if you did that, and if you looked at your operations, you looked at, you know, orthopedics and women's and children's, psychiatry, you know, general surgery, whatever it is, you could figure out our market share, and you could figure out whether or not we're growing or not. And you could put them in these 4 quadrants, okay? And what it said was, if you have a program that is over here, so it has what? Low market share, and it's not growing, we're going to call that a dog. Okay? And liquidate the dogs. So you want to get rid of those projects, okay? If you've got one, though, that's high market share, but not growing, that's a cash cow. Okay, so we're probably not going to be investing a lot of money there. But what we want to do is milk the cow and get as much cash out of that as you can, okay? If you have projects that are high market share and high growth, those are your stars, okay? You want to pump money in there and help them, you know, become cash cows in the future. And then if you have something that's low market share but high growth, it's kind of a question mark. You're not sure. You've got to carefully, that's probably where you're going to spend most of your time evaluating which of those you think you can move this way or which should be divested. And that's kind of the classic Wall Street approach to portfolio management, okay? All right. Now we'll go to strategic planning with that as a backdrop. Okay, so you remember this slide? Okay, this is the one we had last time. It talked about our sources of revenue. And the importance of this is that our revenue model really drives our strategy. They have to be aligned. You can't, you know, have one, you know, a revenue model that says we're going to pay it on fee for service and organize around population health, or vice versa, because it doesn't work. It's counterproductive. So whatever we do, it's got to be aligned with this. And as we saw last week, we said, you know, we've got to have a plan to cover this gap because supplemental reimbursement's going away. And we said that, well, one of the ways of doing that is to convert to population health management, become a global risk-bearing organization, right? Okay, so that's kind of a backdrop for what we're actually doing. This is actually the current draft of the new strategic plan that we're going through, and I think a lot of you are going to see this probably next week because we have this LEAD conference. If you go to that, you're going to see this. But basically it says over the next 3 to 5 years, we're going to transition to be a population health management organization. We're going to preserve our mission, but it's going to be the foundation of our strategy. And we are going to develop the ability to enter into risk-based global prospective payment contracts for key populations. Okay, Medi-Cal, HealthPAC, Medicare, our own employees, and commercial patients as well, okay? So a risk-based global prospective payment contract is capitation, all right? That's an insurance contract. We're going to build on our key competencies, okay? That's kind of getting back to that Boston Consulting Group matrix about, you know, what are our key strengths, and let's focus on those. It kind of also sort of implies that maybe we're not going to be doing some things that we're currently doing, but that's a tough discipline to impose in a not-for-profit healthcare organization. Typically, we never stop doing anything that provides any amount of good to anybody in the community, regardless of whether it's cost-effective or not. It's just the nature of our organization. But we're going to focus on things like ambulatory care, acute, behavioral, and post-acute care. We're going to maintain this culture of accountability, and we are going to partner with other healthcare providers. Okay? So that's the basic strategy. Questions?
So then, how do we move toward, you know, we talk about a culture of accountability.
Yeah.
You know, and it's just a word around here, you know, because oftentimes, you know, you might have 5 departments that you need to work well together.
Yeah.
To move the organization forward, but you only have accountability in 1 or 2.
Yes.
And, you know, what's going on monitoring everybody who has a level of accountability to make the ship move?
Yeah.
What's the strategy for monitoring that and holding people accountable?
Yeah. So one of my favorite quotes is the real problem with incentive systems is that they work. Okay, whatever system you have or don't have, it's an incentive. So right now, we don't have a bonus program. Okay, we do have a performance management program, but it really has no teeth. Okay, there's generally no negative consequences other than getting fired if you're grossly, you know, incompetent. No negative consequence for failing to achieve your objectives, either hitting your budget or hitting your quality metrics or achieving whatever specific projects you've been assigned to do. Okay, so you know, the result of that is sort of mixed. I mean, it's just like, okay, well, if you're a high performer and you're out there doing all this stuff, you should feel good, but okay, but you're not getting a raise, you're not getting a bonus, and you're looking across the hall at maybe your peer or across the organization who's doing none of that and is getting the same result that you're doing. And it takes the spirit out of the organization. So we have to change that. And so one of the things Jeanette and I have been pushing on is to create an incentive program. I mean, one thing is refine this performance management so it has some teeth. And so, for example, we have one thing that says, well, if you don't hit your budget, you're not going to get a raise, okay, unless you get an exception. But what we really want to have is an incentive system, a bonus system for managers that says if you do good work, you're going to get recognized in a very tangible way. So, you know.
It works, like you say, it works.
Yeah.
You know, a lot of the literature out there, I think that's probably funded by people who don't like to pay bonuses. Say,
Yeah.
Bonuses don't work, but they definitely work. I came from
Yeah.
a bonus structure at Tenet.
Yeah.
That was on you know.
Yeah.
The quality of care you provide is definitely a driver behind why you do your
Yeah.
If you know you're gonna get potentially $25,000 at the end of the year, if you hit a mark, you work
Yeah.
that much harder.
Yeah.
So they
Yeah.
work. They
Yeah.
work. I agree with you.
And they can be designed different ways. I mean, when I was at Sutter on the senior team, when we put the first bonus program in, and it was kind of a all for one and one for all. It was like a team thing, and we had like 10 people on the senior team, and 2 of them don't perform. They take the entire team down. Those are that didn't go on very long. You know, that got dealt with. I redesigned a compensation plan for a faculty practice plan in Vermont. And I'd been there like 3 months, and I would talk to the CMO, and I said, gee, Phil, who's the chair of OB and chief medical officer, we got 175 docs, and I think like, we got like 20 guys who aren't doing anything, not working. He goes, oh yeah, we know who they are. I said, well, why aren't you dealing with it? It says, oh, but we're all on salary. I mean, the company just gives us the money. We don't need to. It's not our problem. I said, okay, new comp plan is pay for production. It's by department. We're going to give the chair of the department X amount of money based on the total production of their department. Your problem. How that money gets distributed. Well, guess what? The 20 physicians who weren't performing were gone like that, because the other people are like, hey, I'm not going to carry you, do the work. Yeah, so anyway. We actually are thinking about how far down in the organization to take it.
John
Yeah.
Muir gives a bonus to nurses every year.
Yeah.
Increase age caps and increase
Yeah.
safety.
We're, one of the barriers we have are the union contracts we have, because the unions actually do not want us to give their members bonuses.
What?
Yes.
Wow.
Yes, that's true. Okay. Yeah. But yeah, I think you'll hear next week that it should be on one of the slides you see that we want an incentive system, and we want it approved. We want it approved this year. Is it what?
The reason for them not wanting it, is it because of the
Well, part of it was, gee, we're not for profit. People shouldn't get bonuses if they're doing their jobs. Okay, that's one. Another was, well, gee, the organization's struggling. We can't afford to pay bonuses. And how would that look when we're not paying our vendors and we're paying bonuses? Okay, but now we're coming back to, well, wait a minute, guys. We just did a huge turnaround. We're making money. We're positive cash flow. It's time to reward the people who are doing the work, And we think, you keep talking about culture of accountability. We don't think we can do that unless we put an incentive system in. Okay,
And it becomes a major tool for recruiting talent to the organization.
Absolutely, absolutely, yeah. So you'll get your chance to weigh in on that next week. Okay, all right. Okay, so this is very, very high level, and then the challenge is, well, how do you actually, implement a strategic plan? Because it looks good, but I think 90% of strategic plans, they get printed on this really nice paper, and they're a really nice binder, and people put them up on the shelf and never open them again. Okay, but we can't have that happen. We have to actually make this work. So it's another one of my favorite quotes, which is form follows function. Okay, you cannot implement a new strategy with an old organization structure. You have to change to structure it to implement what you're trying to do. So this is the basic structure that we're kind of working with. And it looks a little complex, but this is sort of a representation of what's called the continuum of care, which is what happens to people as they enter the healthcare system and exit from front to back. And also it is supposed to represent everything that would be included in an insurance product, right? Okay, like, we get paid by insurance companies, so we're acute care. That's a big piece of, how much of the healthcare dollar do you think goes to acute care services? About 30. Much, much less than you would expect.
with the
Much.
population we're looking at.
Yes, yes.
Hard to believe that
It's hard to believe. It's hard to believe. What are the real important things if you talk to insurance companies? Ambulatory access, number one. Post-acute care. Okay? Acute care has become sort of a commodity. The things that people can't get are get their enrollees in to see doctors as soon as they need them, and post-acute care. You guys all know Mark Fratsky. He left, he went to Kaiser. He called me and says, hey, you know, Dave, Kaiser would be happy to lease all of your skilled nursing beds from you today. Okay? Yeah, wow. That's their problem. And why? Because they can't get patients out of the hospital. What do you think what's the most expensive place to be if you're in healthcare? In the hospital. So if you're an insurance company, you think, remember that discharges per thousand? They're driving that down. They're saying anything to keep them out of the hospital, keep them out of the ED. Okay? Yeah, so anyway, so the way this works is these are all things that would typically be covered by an insurance company. Home care, e-visits, wellness and fitness centers even, okay, believe it or not. Insurance companies pay, what do they pay for people to go to fitness centers? Prevent them, keep them out, yeah, keep them healthy, absolutely. Doctor's offices, ambulatory clinics, diagnostic imaging, procedure centers like surgery centers, imaging centers, urgent care. Then you have acute care up here, hospitals. Then you have post-acute care, rehab, skilled nursing, outpatient rehab, home care, okay? Now you notice there's some boxes around these things. So, and these terms SBU stands for Strategic Business Unit, okay? And a strategic business unit is a grouping, an organizational grouping that can function as a unit, okay? So, and also could show up on an organization chart as a senior executive running a strategic business unit, okay? So the business units we've come up with are, one, population health management, okay? As its own unit, not, you know, diffused through the organization, but a specific operating unit with an operating executive and a team to run population health management. Provider delivery or Alameda Health Partners, which we have now. 3 is ambulatory clinics. 4 is acute care. 5 is behavioral health, which we drew around everything because it's got to sort of occurs everywhere. So we have to, not that they're going to be running a hospital, but they need to be looking about what's going on inside of a hospital. And then 6 would be post-acute. Now there's sort of a 7th, which is support services. We didn't call it an SBU, but there's sort of a foundation that we think has to go across the entire organization to support these operating units. So things like finance, HR, IT, planning, marketing, you know, things like that. Okay? All right, so now the next step in a strategy is to turning a strategy into an operating plan, very different, is to go through a business planning process and start getting very specific about what does it exactly mean, how are you going to do it, what projects are we going to do. And this is kind of a high level, what I was doing here, that I actually wrote this one, was, you know, what are the specific initiatives that we need to focus on in the next 1, 2, 3 years, okay? And at the same time, if it's not on the list, things that we don't want to focus on, we might actually stop doing, okay? So it's important to, you know, focus in this manner. And this is actually, I think, going to be the one of the specific breakout work group tasks that you're going to do next week, is to say, well, okay, if we're doing this, which of these should be done, how, when, who needs to be involved, have we missed something, things like that. So there'll be an exercise. But so, for example, in population health, we need an IT infrastructure, which we don't have, and not an electronic health record. We need a population health management system, completely different. We need system-wide care coordination. We need to redesign care coordination. We need to improve throughput, reduce length of stay, reduce denials, and we need to establish gain sharing, contracting with the Alameda Alliance so we can start acting more like a capitated organization. On physician delivery, this is the physicians. They really have a very ineffective billing infrastructure, so that's got to get fixed. Lots of process redesigns issues, lots of productivity issues, a lot of issues with physician contracts. So we have, like a complete redesign going on in that area. In the clinics, they need to be reorganized. If you go to the clinics today, they have different operating models. They really don't report to one individual, so there's lack of standardization. A lot of issues that they don't communicate well together. It's hard to get into the clinics. So there's a lot of redesign work to be done there. In acute care, focusing on operational efficiency, action OI benchmark, service rationalization, which is, do we need ICUs everywhere? How are we going to move patients through the system? Things like that.
But, I just want a quick comment. Yesterday, we were having the discussion with folks about, or day before yesterday, about discontinuing the, providing patients with discharge medication at the bedside when they
Yeah.
went home. Have them go downstairs to the
Mhm.
outpatient pharmacy.
Yeah.
That's the Kaiser model.
Yeah.
Or have them go, give them the option to go downstairs or go to the pharmacy in their community.
Right.
Which we're capable of sending prescription electronically to both.
Yeah. Right.
And, all of these things, because of the way we've operated and because of assumptions
Mhm.
that aren't supported by data, folks are saying, our readmission rates are going to go through the roof because people aren't going to go get their prescriptions filled. And I was just like, what data would suggest
Yeah.
that? Plus, why are the county hospitals around us not doing it and they're not seeing, astronomical readmission rates? I said, we don't have any data.
Yeah, you touched on something that I was actually talking to Delvecchio about this morning, which I think is a key, is really missing here, which is, actual business analysis and planning. Because so many things come up here, and there's just this assumption that, oh, well,
Yeah.
we should do that. But nobody takes the time to do the analysis, come into a room, present the recommendation, and make a decision. In this case, we were talking about, won't name the department, but it's, somebody has their budget reduced by X amount of money, and he said, well, what's the rationale for that? And I said, well, this is an important area, and we've got money in reserve that we can use, but what we really want to see, and this is a support department, we really want to see is the executive do the homework, put together a plan, and say, this is what I want to do and why, and what the expected outcomes are, and come in and present it. Because we don't typically do that. It's just more like, oh, you're cutting my budget. Well, you can't do that because, this is a good thing to do.
Right.
I'm like, well, come in and make your case,
Right.
Just, yeah. So,
But with the discharge medication, that's $500,000
Yeah.
we spend on
yeah,
providing medication. Plus, if we do it the other way, we can collect copays and be in compliance with Stark law.
Yeah.
Because this question is whether or not we're violating Stark law by not collecting copays. So
exactly. Yeah, exactly. Yeah. So that's the
it's
kind of,
revenue generating.
and the good thing about putting an incentive system in place, and it's really important how you design it, but typically, one of the key drivers is system-wide performance. Okay, so like, if the system achieves its budget, there's X amount of money available. If you could do more, there's more money available for everybody. Okay, but if you've got a department, well, what it does is it makes everybody care about the entire operation because everybody's got skin in the game.
Right.
And then you're saying, well, in the past I might not have said something to my colleague because it doesn't really matter to me, and I don't want to disrupt my relationship. But if it matters to you, you'd say, hey, wait a minute, why shouldn't we do this? It's going to be better for everybody, blah, 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 blah. And you start dealing with these tough issues. Yeah, so,
I agree.
yeah.
Because it happened when I worked at San Ramon.
Yeah.
I was, the entire hospital
Yeah.
Nobody got bonuses.
Yeah.
So everybody was like, you know, really on each other to work
Mhm.
together to achieve the goal.
Yeah.
We were more efficient as a result.
Yeah, it changes behavior. It absolutely changes behavior. Okay. I won't go through the rest of these, but you kind of get the idea about what you do. And then here's on the support side. So I mentioned we're meeting as a group, and we're identifying what we all need to be doing to support everybody. So in finance, for example, Lawson is our general ledger. It's not set up to provide the reporting that everybody needs. Then we have EPSI, which is like a lousy budgeting system. You guys have everybody. We hate it. I'm sure you hate it too. We hate it. Okay. This mentions storing financials, revenue cycle, blah blah blah. IT. Okay, huge IT issues. I know everybody talks about the EHR, but there's everything else. You know. I mean, there's lots and lots to do in IT. Human resources, incentives, that's what that is. You'll see more, that'll be more prominent next week. But we're really pushing on that. Facility needs, physician development, marketing communication, and planning and development. Okay, so those are the major areas there. Okay, so that's kind of how you take a plan and then start driving it down. And that's this is all real-time stuff, so it's actually very timely for you guys. Okay.
I don't know if there's any measurement for it, but I talk to my team about it all the time. We talk about around here what's so frustrating for me is the work that it takes to get to the work.
Oh, no kidding.
So
Yeah.
50% of your energy is expended on getting to the work you need to do. And so what does that translate into in terms of dollars and cents and revenue that could be generated if
Yeah.
all of your time is spent
Yeah.
actually working,
Yeah.
on the work?
Yeah, so I'm thinking about that in a couple of different ways. One is I'm thinking about this sort of business planning process, that if we had that, and it doesn't have to be elaborate, but it's just more of a discipline of asking questions and forcing people to come in and make their case, and providing them a forum where they can do that that discipline speeds decision making. And the other thing is I'm thinking about everybody's time, because all this stuff we put up there is a lot of work. And so the point I've made is, we have to stop doing some of the things we're doing, because you can't just pile it on and expect it to get done. You've got to stop some things. So in my area, for example, budgeting process. That's taken 3 months out of everybody's year, and frankly, it's kind of been a waste of time, because we end up at the same place. Okay, so we can do that a better way. Monthly variance reporting. You guys are probably clicking away doing this stuff. Maybe we change that. We say, okay, if you're on budget, you get an exemption. I don't know. Yeah, but think about this next week, because you're probably going to be asked, what do we need to do differently to make this happen? Okay, if you've got an idea on things that really add no value, and competencies. Okay, everybody's I don't know how many hours it takes to do competencies, but I don't deal with radioactive material anymore. I used to in the Air Force, but those are big bombs. It's just and the other one is the performance evaluation process. You guys have a lot of nurses. How much of your time is taken up in that? And how much added value do you get? How much does it add to you, or does it add to your employees? Not much. Yeah, so maybe.
The process of doing it is so hectic.
Yeah.
You send it to them, they sit on it, you constantly email it, they send it back, you send it, it's just.
Oh, and I got this, the first time I looked at the thing to fill, I said, are you kidding me? Are you kidding me? Seriously.
It's easier to do it on paper.
It really is. It really is. It really is. And just scan it in and you're done. Yeah, it's just
Now the
this.
problem is that when it's done on paper, you scan it and send it to HR. They send you email that they never receive it.
Yeah, it's just.
You have a record of it.
No, this is your opportunity. There are things like this next week. Get them on the table. So we got to change this. 'Cause
That probably gives nursing about 4 hours.
Yeah.
Yeah.
We need our own.
No, and think of it in terms of return on investment. And don't think of it in terms of dollars, think about it in terms of your time. Okay, is the organization getting a return? Are we spending your time efficiently?
Well, what I've said, and I don't mean to belabor you, but what I've said to folks is, you know, if you tell me that I need to get to Sacramento and I can go in this car, there are some things I need to know. If you say
Yeah.
I need you to be there by noon and it's 1:00, you know, I need to know that that's not even possible based on the goal
Yeah.
that you've set
Yeah.
for me. So
Right.
we need goal examination. Then,
Yeah.
you know, how am I going to measure my speed, how much gas I have, if the car is
Right.
overheating? What's my dashboard for performance? You know, what are my metrics to tell me before the car stops on the side of the road? Because the car running out of gas shouldn't be my first warning
Yeah,
that,
yeah.
you know, I'm running out of time to
Yeah,
get there on time.
yeah.
You know, so when we asked for the shift management tool, you saw what that did.
Mhm.
You know, when we started looking at
Yeah.
our productivity soon enough and frequently enough, we performed at a very high level because we
Mhm.
had intel.
Yeah,
You
right.
know, it's the same thing in quality. Our quality data is so bad. How do we truly improve the quality of care if
Yeah.
if we are not able to measure it
Yeah,
consistently
Yeah.
and timely enough for me to say, okay, this patient's still here, this is going on, let me go fix it now before they leave.
yeah.
You know, that kind of thing. And so
Okay.
we just need the intelligence in order to do our job, you know.
Good.
And that's
Okay.
not there.
Well, let me tell you that this lead session next week, and I had a big hand in designing it, I think is going to be the first time we're actually asking for real feedback and giving people a forum where they can do that. So this is, tell your colleagues, this is your chance to have a big impact on the direction of this organization. Okay? All right, okay. We're going to finish up with budgeting. This will go pretty quick, just because we're right in the process, but this has actually got approved by the board last night. So we have an approved budget in there.
Congratulations.
It took about 5 minutes. So the level of confidence the board has in this has gone way up, and nice board meeting.
That's actually indicative, I mean,
Yeah.
I see that in patients I run on, their level of confidence has gone up.
Really?
Oh, it's huge.
Yeah.
When we round on patients, they want to come back, they want,
Yeah.
they're happy here. Yeah, and they feel like, don't you feel that? I mean, so, for the board to feel that, that's great.
Right, 'cause they'll start off like, oh, I've heard some bad things, you know, but I'm glad, you know, had excellent care.
Yeah. Okay.
So that's good. It's
Very good.
all the way up.
You know, it has, and you know, for example, you know, we're involved in the startup of a new health plan called Canopy Health, which is, we used to call it Bacon. I don't know if you've heard that term. Bacon. It's now Canopy Health. Bacon was just too, you know.
Very healthy.
But they're gonna start on August 1st with UC employees, and it's you know, all the big players in the Bay Area. So UC, John Muir, us, Dignity a little bit, Hill Physicians, but not Sutter, not Kaiser. Okay, so one of the problems is they need a delivery system in the East Bay. Okay, in particular, they need OB services. So one of their guys on the board approached me last week and said, hey, you know, could we come over and get a tour of your new OB department? Because, you know, the option currently is, you know, drive across the bay to UC or drive up to John Muir, and, you know, the enrollees out here may want to use Highland Hospital. So that's cool. Yeah.
We've already toured all of the clinics, including West Oakland,
Yeah.
which is a big clinic group, and they were, I toured the COO last week,
Uh-huh.
and they were thoroughly impressed. And so
Wow.
I've already in the process of a plan for them.
Cool.
Yeah.
Yeah.
We're
So
ready.
exciting. So
We
we're
just
we're
need more
moving.
nurses.
So we're moving. Yeah, need nurses. Anyway, so one of the things we did is we said, okay, this is what we're trying to accomplish, and we always lead with this because we want to respond to them about their feedback about you need to be accountable, but we also want to say, and this is what we need to be accountable. We need an incentive program.
Right.
Right back at you.
Yeah.
It's going to support strategic plan, and that's what all that work was. All those initiatives, we're saying we're going to look at all those. That's what we're going to be doing. We're going to hit our margin, have capital budget, $30 million. continue to improve operationally, improve on a business unit level, which of course can be different, you know, and basically demonstrate a credible budget that can be achieved. And they're actually at this point like, oh, you guys are actually hitting your numbers. It's like that's not been our culture here, but it happened. So there you go. Okay, go through this. This is really, we wanted to just kind of go on record about some of the achievements that were actually done. So comprehensive review, budget oversight, FT committee, variance committee. I know you guys probably, that seems like a nuisance, and we're gonna retool those. But at the beginning, it was really important to have these to gain sort of an appreciation for where managers were in their skill levels, understanding their budgets and everything. So I think it's been good overall. But this is probably one of the areas where we can talk about time saving and how we use those processes. Real productivity improvements were achieved. And this is where we actually gave you credit, Michelle, because that's talking about what you just described. And then we talked about things we're doing next year. So obviously we're adding new positions, CMO, COO. So it's going to be a very different organization next year. And talk about retooling these committees. And did we put? Oh, I missed the opportunity to put incentive system in there, but they've heard it. So, okay. So here's the final budget. Actually, it's pretty close to our original target. We're budgeting $921 million, a 5% EBITDA margin, so $46 million in cash flow. And the way we're going to use that is $18 million for debt and $30 million for capital expenditures. And again, you know, we need to go back and decide exactly how we're going to spend that. So this IT strategic planning process we're going through right now is extremely important. So I hope some of you get involved in that.
All the directors in nursing are,
Okay.
are the, what do they call it? Selection committee. Is that the same thing?
No, no. So I know that they do have that going on, but we actually have an IT strategic planning process going on with a company called Leidos. And what they're going to do is assess all of the IT systems in the organization and identify where we need to be in 3 to 5 years, and then a plan to get there. And then once we have the plan, then we're going to decide which systems we do sooner than later, and then do a selection process, and they would then drive that. So the current process, I'm not sure exactly. It seems a little premature to me, but you know,
They
it
have,
wasn't my decision. So
we have meetings set up with them.
yeah,
Starting as soon as next week.
okay,
So we are participating in terms of
yeah,
talking to them.
good. Yeah, and it's important when you talk to them to, you know, sort of focus on the functionality that you need that is affecting your, like one thing I hear from Kinsey all the time is the Chronos system. You know, it's just, you know, needs the next version or something better. It would just save a lot of time. So I'm sure there's a bunch of, and then the other hospitals, of course, aren't on anything, right? You know, they need to be connected. So then we kind of went through, you know, we've talked about all these things, so I'm not going to go through them, but you know, how we expect to get to the budget. And here's just more detail, and then this is graphically. So this is showing a nice improvement to profitability, good ratios, so things are looking good. And then this is actually the last slide, just to finish on, you know, how important capital is, which is a lot of what we've been discussing about is how we spend this money over time. So that's it. So we're done. This has been really good for me.
Oh, it's been great for us.
Thank you
Yeah.
very much. Thank you.
Yeah, my pleasure.
Positive feedback from a lot of people.